Good evening and welcome to the Immunisation Coalition's 2022 Annual Scientific Meeting. My name is Lou Irving and I'll be your moderator for tonight's sessions. Firstly, I would like to acknowledge the traditional custodians of the various lands on which we work today and the Aboriginal and Torres Strait Islander people participating in this session. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. So the evening session on a Sunday for the last 31 years has always been about pandemics past, present and future. And this year I'm delighted that our first speaker is Professor Ben Cowling. Interestingly, Ben has been with us for the last 3 years at the time of the COVID pandemic. Professor Cowling is head of the Division of Epidemiology and Biostatistics at Hong Kong University. He is also co-director of the WHO Collaborating Centre for Infectious Disease Epidemiology and Control at HKU SPH. Tonight, Ben's presentation is entitled Epidemiology, Public Health and Modelling. Welcome, Ben, and thank you for joining us again.
Thanks very much. It's my pleasure to present again. I was here 2 years ago, and I think I also did a talk last year. I'm going to spend the next 20 minutes talking a little bit about what's been happening in Hong Kong and also making some general observations about COVID epidemiology and also modelling. The first thing I want to say is 3 years ago, my colleagues and I worked on a document for the World Health Organization looking at pandemic and epidemic influenza control measures, non-pharmaceutical interventions, the kind of measures that could be used, what might happen in the next influenza pandemic. We looked at quite a range of public health measures listed on the slide here. I think it was 19 in total. Really a lot of different measures that could be used in the next influenza pandemic or indeed a severe epidemic. And we came up with a bunch of recommendations. But I think now with the experience from COVID-19, a lot of this may change. We've learned a lot about how to respond to COVID. And there's some interventions that we've used for COVID that are not even in this list. For example, stay-at-home orders. We thought in this review that travel-related measures really wouldn't be likely in an influenza pandemic, but for COVID, we've seen them for 2 years now. So I'll come back to this at the end, but I think the use of non-pharmaceutical interventions is a fascinating area for further study. In Hong Kong, where I am, we've had now a number of community epidemics of COVID, but nothing much in the past 6 months until very recently. We've had an approach to COVID, like in Australia, where we try and keep numbers low and ideally try and get them down to zero so we can have a period of calm in between any community epidemics that do occur. The new community epidemic is quite exciting because we've had introductions of Omicron and Delta as well in a relatively short space of time. And the time of recording, there's increasing numbers of cases and it is getting quite exciting actually. One of the observations we made in Hong Kong in the early days was the super spreading phenomenon that we're familiar with for many different infections actually, that a minority of cases are responsible for the majority of transmission. This was work with Dylan Adam, a postdoc of mine from Sydney before. And in that study for super spreading, we made the observation that 20% of cases, or actually 19% of cases, are responsible for 80% of the transmission events. This was in mainly our second wave in Hong Kong. And also that the majority of cases didn't transmit to anyone else. Now, one of the things we've just been working on recently is actually trying to look at whether this phenomenon is similar over time or whether there's any evidence that it's changing. And actually, in contrast to what we were maybe imagining, we found that if anything, super spreading potential actually seems to increase as an epidemic becomes controlled. In other words, on the left is our second wave mainly, the middle is the third wave, the right is our fourth wave on the left of this screen, and on the right of this screen we have our estimates of the overdispersion parameter K, and a smaller number means more overdispersion, and the bottom panel in orange is the proportion of cases responsible for 80% of transmission, and we have a ballpark of 20/80. So 20% of cases responsible for 80% of the spread. What we thought was that in the early days of an outbreak, there's a lot of super spreading, and one of the ways we can control COVID is by getting super spreading under control, by reducing mass gatherings, by asking people to tend to avoid larger groups and so on. And so we thought that maybe there'd be less super spreading, but actually, if anything, there's more. We see in each of these waves a general trajectory downwards of the proportion of cases responsible for 80% of the transmission, whereas time goes on, it's a smaller and smaller proportion. But of course, at the same time, the reproductive number is coming down. So in the context of an epidemic being controlled, what we find here is that it's maybe not controlled exactly by stopping super spreading in the way that we'd imagined. But we're continuing to look at this. This is preliminary work, and I think it's fascinating. I think last year I showed you some results where we showed the serial interval isn't constant over time, it changes over time. That was in China, and we have the same finding in Hong Kong. And here now we're also showing that the super spreading dynamics are not constant over time. It's actually fascinating to see that these epidemiological parameters that we often think may be relatively constant actually do seem to change over time as a consequence of control measures and perhaps changes in behavior. Now, we have vaccines in Hong Kong, of course, but the uptake hasn't been as good as in some other parts of the world. The top left here, I put Singapore and mainland China for comparison, where we've just about hit 70% double dosed in Hong Kong. On the right-hand side, again, is the hesitancy, which has been fluctuating a bit, but in the last 9 months, we've eventually crawled up to 70% coverage. But at the bottom, we have a problem. So this is the age groups with the youngest at the bottom, where we've just started vaccinating 5 to 11-year-olds. The older children, 12 to 19, and the younger adults, all those groups are above 80% with at least one dose and approaching 80% double dosed. And then the elderly, if you look in about the middle of the slide, the age group 70 to 79, only about half have 2 doses. And the 80 plus individuals in Hong Kong, who of course are the highest risk for COVID if we do have an outbreak, we only have about 20% double dosed. And now we have a community outbreak with Omicron. We also have Delta in the community with increasing case numbers. This is a real problem for us. We've had hesitancy in the early days of the pandemic because of reports of side effects. And I don't think the reports were necessarily false in the way that we know there can be some side effects triggered by vaccination. There could be Bell's palsy. We've also recently reported triggering of shingles, reactivation of shingles after vaccination. We've reported some evidence of an excess of cardiovascular events after vaccination. But we know these are all rare, and the benefits of vaccination far outweigh the risks. But of course, in Hong Kong, we haven't had any COVID for the last 6 months when the vaccination campaign's been running. And that means that for an individual, when they do the risk benefit calculation, it's actually quite complicated because you're thinking about the immediate risk of a side effect versus the longer term benefit if COVID comes back, when it comes back, and maybe delaying the decision. So the older people may not exactly be against vaccination. They're just in many cases delaying the decision or putting it off. And now it seems like it's really a very urgent priority to get vaccine coverage up in this group as soon as possible, given that we have COVID in our community. Now, the approach in Hong Kong is called dynamic zero COVID. It's basically zero COVID, but I think there's a clarification that we have 2 phases, and that's where the dynamic comes in. And it's the same as in Australia, actually. So when daily cases are at 0, we focus on trying to stay at 0 by minimizing the risk of the virus getting into the community. In Hong Kong, we have now 21-day quarantine for returning residents. At times in the past year, it has been 14, and it was briefly 7 days quarantine for fully vaccinated travelers coming back from certain locations. But we do recognize there's ways that the virus can still get into the community, even with these strict measures. And so there's always going to be a risk of an outbreak occurring. And so that's the second part. That's the dynamic part. If there is an outbreak, when there's cases in the community, we have to try and crack down on it as quick as possible. In Hong Kong, we're doing a lot of testing. We isolate cases outside the home. We have contact tracing, and we have quarantine of contacts outside the home And right now, we're even doing quarantine for contacts of contacts, which means that if I myself am detected as a contact of a known case, then I need to go to the quarantine facility for 14 days, and my family members need to go to the quarantine facility for 4 days. If I'm negative for those few days when I'm in quarantine, my family members can go again. But if I turn out to be positive, then it's like getting another step ahead of the transmission network by doing the contacts of contacts. And we've also had moderate social distancing measures in the community to slow down silent spread. So that means school closures, working at home policies, cancellation of large gatherings, closure of bars, karaoke, cinemas, and other kinds of things like that. So we've never had a total lockdown in Hong Kong as a city as a whole, but we have had quite a lot of social distancing in the past, particularly in our major community epidemics. I've been thinking a lot about how could zero COVID be sustained, because in Hong Kong the government's been very keen to get back to zero and to talk about how in Hong Kong we're going to stay at zero cases so that we can have an open border with mainland China, where a lot of people want to go backwards and forwards for business and for family reasons. So how could we do it as well as possible? Because if we're going that way, we better do a good job of it. And I think for the stay at zero phase, what we recognize now is that we really need a purpose-built quarantine facility for on-arrival quarantine. It could also be used for close contact quarantine, but for the on-arrival quarantine, for keeping the virus out of the community, it's really critical, I think, that we do that as well as possible. We ideally want it watertight. And one of the things that's done in the mainland now, in major cities in mainland China, their on-arrival quarantine facilities have space for the staff to live on site. It sounds harsh. It sounds like maybe a job that you and me wouldn't want to do, but that's the reality in mainland China, that the staff live on site and they themselves have to quarantine before they can go back to visit their families at home. And this kind of facility could also, of course, be used for aircrew, particularly visiting aircrew, and maybe people who work at the interface between the borders. So on the right-hand side is a very nice study from New Zealand that I refer to in some of my presentations, looking at how leaks of COVID got into the community in New Zealand. And it's interesting because I couldn't see a single one where there was a quarantine that was too short. For example, in Hong Kong, we have 21 days quarantine because we've had people coming out of the end of quarantine and maybe thought to have a long incubation period, and so we need to make it longer. Actually, that's not the case. We've had people, and just one of our outbreaks right now was caused by a person infected on the day before they left quarantine hotel, and then of course they're out and they're infecting people in the community with the virus. So that's a leakage because our quarantine hotels that we use in Hong Kong are not built for quarantine. In New Zealand, you can see all these different outbreaks. It's aircrew, it's transmission in the quarantine hotel, it's staff who work at the port, staff who work at the airport hotel, and so on. And all of these things, basically every single one of these outbreaks could have been prevented if there was a purpose-built on-arrival quarantine facility as a kind of firewall. But obviously, that's not going to be easy to sustain. I'm not sure if it would be feasible in Australia or New Zealand, if it would be attractive for people to actually to work and live there. But that's the reality of how it could be done perfectly, I think, and to make it sustainable. And of course, in Hong Kong, we're not only thinking about doing zero COVID until vaccine coverage gets to a high level. The government in Hong Kong is thinking about doing zero COVID for more than the short term, into the medium term. For the get back to zero phase, I think in the mainland, they're really the place that's done this most effectively. And at the moment, what happens whenever there's an outbreak in a city, as soon as they find the cases, they immediately do a lockdown either of that area of the city or the entire city, and then they test everybody. And so the intervention is not actually the lockdown. The intervention is not the stay-at-home order. The intervention is the mass testing, isolation of cases, and quarantine of their contacts using CCTV, mobile phone records, a lot of other information to find out where the cases have been and who may have been exposed. Once they've sorted all that out, everybody else can go back to normal. And the rationale for the stay-at-home order is if they didn't do the stay-at-home order, by the time they catch up with the cases and by the time they do the contact tracing, the virus may have moved on. So the lockdown is like the pause button for the outbreak. It's really smart. So you do a lockdown for a week, that pauses as much as possible the spread of infection. It may still be in the family, it may still be in the building, but it's not in the general community. The mass testing tells you who's infected, and it's repeated mass testing. And then you can do isolation and quarantine, the targeted measures, and everybody else can go back to normal. In Hong Kong, we can't do this. We don't have enough lab capacity to test everybody. We don't have a way to get everybody to stay at home. And we don't have really the logistics to do it. In mainland China, they have what's called a health code app, which is an app that they can require everybody to get tested if they want freedom of movement, and can also collect a lot of other information useful for contact tracing and so on. So that's the way they can implement it. But in Hong Kong, I'm not sure it's feasible. And actually, this is the problem I think we have in Hong Kong with the sustainability of zero COVID. And I've been advising the government for a while that zero COVID is maybe the optimal strategy in the short term before we have vaccines available. But in the longer term, I'm not sure it's sustainable. For Hong Kong, we've been thinking, what's the advantage of keeping going with zero COVID now that vaccines are widely available? And really, it's the thing in the middle. It's the hope for quarantine-free travel with the mainland. There's been various surveys of Hong Kong residents, and the majority view is they would like the chance to go into China and back again without quarantine, to visit their family or for business reasons. And that's really a priority for the government here. But we can't have a quarantine-free travel with the mainland unless we have a bubble like the Australia-New Zealand bubble. We've both sides have got to be at zero and convince each other that it's minimal risk. All right, so we've been looking in Hong Kong. I just want to share a bit of data on antibodies. We've been looking at Hong Kong at antibody levels after the two vaccines we have available, the inactivated vaccine by Sinovac and also the mRNA vaccine from Pfizer. And in Hong Kong, it's marketed by Fosun Pharma rather than Pfizer. We see dramatic differences between the two vaccines in terms of antibody levels. On the left is a study in healthcare workers that we published in Lancet Microbe, and in the right is a study in the general community just using the surrogate virus neutralization assay. And on the right-hand side, we see very substantial differences with 2 doses of the Pfizer vaccine giving very substantial antibody levels that don't wane particularly quickly, whereas for Sinovac, the waning happens more quickly, and it actually comes down to a low level fairly soon. So we're now doing studies of third doses. On this slide, I'm showing data from a study of giving a mRNA vaccine to people who previously got inactivated vaccines. So this is inactivated, and then mRNA as a boost, and it works very well. It works very, very well. So on the left is the ELISA and the SVNT. On the right, we have the PRNT, not only for the original strain, the vaccine strain, but also we have it for the Omicron variant. And we see pretty good levels of antibodies against Omicron for people who get this boost. And I think in Hong Kong, we're going to have data fairly soon on how well the two vaccines are performing against Omicron, both in terms of limiting infection, but also in terms of limiting severe disease. And I think one of the limitations that we have currently is we have a reasonable idea of how to match and map antibody levels to protection against infection from working, including work done in Australia. We have a fairly good idea of how that works approximately. But for severe disease, we don't have a corresponding idea. And if we can't prevent infection, we need maybe some other immune mechanisms to give us that amelioration of disease severity. And so for Hong Kong right now, I'm often asked what's the level of protection the vaccines are going to provide against severe disease, and for Sinovac and for the Pfizer vaccine. And it's very difficult to have an estimate, actually. We know that the Pfizer vaccine will give a much higher level of protection against infection. And if you can't get infected, you can't get severe disease. But for Sinovac, I think is still unclear. And there's not too much data from elsewhere in the world that we can draw from. One of the observations we're just making right now is that the transmission of dynamics of Omicron seem to be different to what we've had before. We never had any of the other variants. We never had Alpha or Delta until now as well. So in the past 2 years, particularly a year ago, we started having a policy in Hong Kong where anytime there was a case in a residential building, all the residents of that building got tested routinely, just in case there was any transmission in the building. And we never really found it. The the plot on the bottom left of this slide is outbreak size for buildings, and it's basically not outbreaks. It's just typically family transmission, occasionally spread to one other flat, and just a small number of cases where there were more than a handful of cases in a residential building. The maximum was 26 cases in one building, and now in Hong Kong we have quite a number of residential buildings with outbreaks. The largest is more than 200 cases, and there may still be more coming. So it's a remarkable shift where all of a sudden Omicron seems particularly able to spread easily within residential blocks. We don't know exactly how. And we're also today having what's reported as a Delta outbreak in another residential block. So it's not only Omicron. And I really want to know how this is happening in our residential blocks, because the mechanisms are not yet clear. I'm coming to the end now. One of the commentaries I recently published was about how it's important not only to assess transmission dynamics at the beginning of a pandemic, and I think probably a year ago or even 2 years ago, I gave you some estimates from the early days in the pandemic of incubation period, serial interval, and severity as well. And I think what we recognize now, 2 years into the pandemic, is that these things can change. Omicron clearly has a shorter incubation period and a shorter transmission cycle, and Delta as well. And I think it's really, really important to keep monitoring all of these quantities. I remember in Australia, there's been a proposal in the past for doing first few hundred type studies. And I think it's clear now that we need more than those. We may need not only studies of the first few hundred cases, but continuous assessment, the next few hundred, and after that, the next few hundred as well, and keep going as a pandemic develops. Be ready to update these parameters. In terms of what's coming next, I like to look at the CDC forecast to get a sense of what they think is going to happen. I don't know how good the predictions have been, but they're all documented, so it is possible to go back and see how they've been doing. In the US right now, the forecast is that the cases are going to gradually come down, particularly hospitalizations are going to gradually come down. And I think that's good news, because that's, to me, signaling in the US we're getting to the end of the pandemic phase, and we're moving into a phase, maybe not exactly endemicity, but maybe epidemicity, where we're going to have repeated epidemics, but we may not be able to predict when or exactly what they are, but we know that there'll be more epidemic waves. In the longer term, back in early 2020, there was a nice study in Science from some collaborators of mine from Harvard looking at what might happen in terms of future waves. And I really wish that any of these four had actually panned out, because I think what's actually happened in the last 2 years is worse than any of these figures looked. We've had enormous second, third, fourth waves. We've had a lot of things happening. The virus has evolved to be more transmissible and cause a lot more impact and be more difficult to control as well. I think it's difficult to say what exactly is going to happen in the coming months, even the coming years, how the virus might change, how immunity might change over time. And these are really important areas for further study. So I think in terms of non-pharmaceutical interventions that I mentioned at the beginning, when we look at what might happen in the future, for influenza pandemics, I think we can revisit the playbook and see, for severe influenza pandemics or for moderate influenza pandemics, what can we learn from the response to COVID? Border closures for flu pandemics may not be as infeasible as we thought. And I think we can look much harder at the different options for work at home and how much impact work at home policies might be able to have in influenza pandemics. Look again at stay-at-home orders, because we didn't even review those in our review of non-pharmaceutical interventions. And I think that setting aside influenza pandemics, now for seasonal influenza epidemics, there might be more enthusiasm from local government officials and even national leaders to propose NPIs for flu seasons. In the past, I think there's been an impression that there's not a lot that can be done in terms of public health measures. Now we recognize that things can be done. It's just a matter of the justification, whether it's worth it to go to that trouble, to have that kind of disruption to limit something like influenza. And I think it probably would be. So my final slide, So I think in Hong Kong, we're doing the dynamic zero COVID approach. The government really wants to get case numbers back down to zero again. I think it's worked as a short-term strategy until we have vaccines available. I'm not sure that it's justified in the longer term, but the government very much wants to have a travel bubble with mainland China. And in the mainland, there's no sign that they're planning an exit from zero COVID. It suits them very well, and keeping infections at a low level has many advantages for them. But for Hong Kong, it's going to be tough for us. My own research now is still looking at population immunity. How can we measure the level of population immunity at any particular time? And for COVID, we recognize that's immunity against infection, probably with antibodies, but also we need to think about immunity against severe disease, because if we have epidemics of COVID or other things, but they don't cause severe disease, maybe we're not so concerned as if there's a lot of severe disease. I'm continuing to work on optimal vaccination approaches. And for flu, I've been doing that with timing and strain composition and so on, looking at repeat vaccination effects, blunting of immune responses and so on. And I think for COVID, we're going to start to face these kind of challenges. In Israel, there's reports of blunted responses to fourth doses. Maybe they've given them too close to the third doses. Let's see. I think we need a more careful study of this as time goes on, and we do think about revaccination again. What's the right interval? Are there going to be issues with antigenic seniority or other phenomena that we've recognized and studied with influenza for a while, but hasn't yet come up with COVID? And then for the future, what's next after Omicron? I don't know. We didn't anticipate Omicron, and I really don't know what to expect next. So thank you. It's my pleasure to present today. And I just wish I could be there in person, and maybe next year, if you'd invite me back, I hope that it would be an in-person conference and I'll be able to leave Hong Kong. Thank you very much.
Thank you, Ben. Our next speaker is Dr. Kirsty Short. Kirsty is an influenza virologist by training with extensive experience in emerging viral pathogens and pandemic preparedness. She has now turned her expertise to working on SARS-CoV-2, and in particular the role of children in disease spread, the impact of this disease on people with diabetes, and the development of new antiviral therapies. Tonight, Kirsty will be discussing pandemic proofing for our future. Welcome, Kirsty.
Thank you very much for the introduction, and thank you for the opportunity to talk today. So today I want to talk about a pretty big picture topic, and that's really about pandemic proofing our future. So I'd like to take you back, cast your minds back to 2019, a simpler time. And what you can see here was there was this paper that looked at global epidemic preparedness and basically ranked countries on their preparedness. So countries that were ranked 1 were ranked as very, very prepared for disease outbreak. So you can see Australia, New Zealand was prepared, the US, most of Western Europe. And you can see really that this sort of correlates with GDP, that countries with a higher GDP tended to be more prepared for disease outbreaks. Fast forward then to 2020, 2021, now 2022, and let's look at the countries that actually did do well in the pandemic and did do poorly in the pandemic. So this is the list of the countries that had the highest COVID-19 death toll. And here on this list, you can see numerous countries that were actually ranked as globally prepared for a pandemic. So the United States, the United Kingdom, Italy, France. So what can we conclude from this disconnect? I think the first thing we can probably conclude is that politics probably disproportionately affects pandemic preparedness. And I'm not going to go into all the political natures of this COVID-19 pandemic. I think it's really summed up with this picture of Boris Johnson, who's got his tie tucked in nicely, safely, visiting a hospital and not wearing a face mask. But I think the other thing that we can conclude from this disconnect is that perhaps we need a new approach to pandemic preparedness and how we think about upcoming global pandemics. So obviously the big question is what will be the next pandemic, because there will be another pandemic. And the short answer is we don't really know. We've got lots of great candidates. So we've got the hemorrhagic viruses like Ebola, Marburg, Lassa. Of course, there's MERS coronavirus, there's Nipah, and my personal favorite, influenza virus, which has caused pandemics before. Or there could be another virus that we've yet to identify. The problem that we have is because we don't know what virus will cause the next pandemic, it's very risky to depend on a virus-specific approach to pandemic preparedness. So what I mean by that is if we prepare for the next influenza pandemic and invest everything into influenza antivirals, the next viral pandemic may be Nipah, for example, and then our influenza antivirals aren't very useful. So what I want to pitch to you guys today is really this idea that pandemic preparedness should focus on a pan-viral approach. So what we should look at is from a vaccine perspective, we should focus on the universal vaccines, so say universal flu vaccines, pan-coronavirus vaccines. When we talk about therapeutics, we should really look at host-directed therapeutics that are more broad spectrum rather than specific antivirals like oseltamivir. We should look at pan-viral prognostics. So prognostics will help predict the clinical course of a patient. And they're very important in an outbreak scenario because they facilitate both patient triage and resource prioritization. And then actually when we talk about diagnostics, we also need this pan-viral approach. So this ensures that no matter what virus causes the next pandemic, we at least have some level of preparedness. So today I'm going to talk about these bottom 3 points because I think talking about universal vaccines can be better covered by others. But I'm going to talk to you about a pan-viral approach for therapeutics, prognostics, and diagnostics. So let's start with therapeutics. And let's use COVID-19 as an example because now we've got a few antivirals that are being used in the clinic against COVID-19. So for example, molnupiravir, Paxlovid as well, and of course we have monoclonal antibodies. But the problem with these is that whilst they may be great for COVID-19, they wouldn't work against another virus such as influenza, Nipah, Hendra, so on and so forth. Instead, what option we have is we could actually do a pan-viral response by targeting the immune system. So what I mean by this is we know in COVID-19 that the immune system and sort of dysregulation causes a lot of the severe disease. What's really important and interesting is we see the same thing in many other potentially pandemic viruses. So if you look at avian influenza, we see very much the same thing. We have this hyperinflammation. MERS in severe cases, there's hyperinflammation. So this affords us the opportunity to develop drugs that target the host and therefore could be used across multiple different viruses. Now, there's some caveats to this, and I think the important caveat to note here is with dexamethasone, which has been really effective for severe COVID-19, but is actually contraindicated for avian influenza, for example, when it spills over into humans. So whilst you might think that that sort of goes against my argument for a pan-viral response, I think what it speaks to is that we can't have these broad spectrum immunosuppressants like dexamethasone, but we really need to nut it down to pathways, to specific cell types, to specific mechanisms to develop something that we could actually feasibly stockpile and have on hand ready for the next pandemic. One thing I want to talk about in terms of developing therapeutics for the next pandemic is the importance of using the right cell type. And the perfect example for this is hydroxychloroquine. And of course, we all remember that initially a lot of people were promoting hydroxychloroquine for the treatment of COVID-19. We, of course, had Trump saying that this was going to be a game changer. But then, of course, on the flip side, you have, after months and even years of clinical studies, you have the World Health Organization and other organizations coming out confirming that actually hydroxychloroquine does not prevent illness or death from COVID-19. So what went wrong? Why did we have this initial promising evidence that maybe hydroxychloroquine did something, and why did it never amount to anything in the clinic? The reason for that was basically the wrong cell type. So to understand this, I want to walk you through a little bit about the entry mechanism of SARS-CoV-2. So SARS-CoV-2 has two entry mechanisms. The first is the virus combined to the cell receptor ACE2, and then the spike protein is cleaved by TMPRSS2, and that causes the viral membrane to fuse with the cell membrane, and the genetic material is released into the cytoplasm. Alternatively, what can happen is that the virus can bind to ACE2 and be taken up in an endosome. Then cathepsins in the endosome can cleave the spike protein, and that facilitates fusion of the viral membrane with the endosomal membrane, and the genetic material is released. So hydroxychloroquine targets this cathepsin pathway. When hydroxychloroquine was first tested in the lab and in vitro studies in the lab, this was done in cells that didn't express TMPRSS2. So of course the virus was entering almost exclusively via this endosomal pathway. So hydroxychloroquine looked really promising. Unfortunately, in the respiratory tract, most of the cells that are expressing ACE2 are also expressing TMPRSS2. So in fact, SARS-CoV-2 is not using this entry mechanism, but rather is using this entry mechanism. And this entry mechanism is not affected by hydroxychloroquine. So this is a really key example of how using the wrong cell type in vitro, and these were studies done in immortalized cell lines, can actually lead you astray when trying to clinically translate something. So I would say in the future of pandemic preparedness, really we need to push towards primary cells, organoids, things like lung on chip, as a way of ensuring that anything we test in the lab can be translated to the clinic. And I just want to show you a little bit of data that we have using this method. So this is to study SARS-CoV-2 transmission. And so we wanted to model the cells in the upper respiratory tract, specifically in the nose. So we cultured primary human nasal epithelial cells at an air-liquid interface. They're shown here. You can see that just like cells in vivo, they express cilia. They have these goblet cells to produce mucus. They produce really nice tight junctions. And because these are a really good model of the in vivo system, we can actually use them to study SARS-CoV-2 replication and the different viral variants. So this is some of the data on the right. What you can see here is virus replication in these cells in either pediatric donors, so that's shown in pink, or adult donors shown in purple. And this is shown, these first two columns are shown for the wild type virus, so the original virus. And what you can see here is that this virus really didn't replicate well in pediatric epithelial cells. And this affords us a sort of mechanistic explanation as to why initially in the pandemic, we really didn't see many infections of kids, and kids had very sort of mild disease. You can see the same trend with Alpha, the same trend with Delta, and maybe to a lesser extent with Omicron, but it's hard because we don't have many data points because we've just started working with Omicron. So there is probably some intrinsic level of protection that kids have against this virus from their epithelial cells. But what you can see is that over time with the variants, that the virus replicates so much better in these cells than the wild type virus did. So if you look at in pediatric donors with Omicron, we're talking about sort of 2 logs higher than pediatric donors with the wild type virus. So again, this primary cell system offers us an explanation as to how these viruses have become so much more transmissible over time, and perhaps why we're seeing so many more pediatric infections today. All right, so I'm going to leave therapeutics there and go on to prognostics. So as I mentioned, prognostics are really important for clinicians to help get an indicator of what the likely outcome for a patient is going to be. So a patient who, say, presents with to the hospital positive for SARS-CoV-2, and you want to know in 2 days, is that patient going to be fine and at home recovering, or are they going to be in the ICU needing ventilation? And so we started looking for SARS-CoV-2 for a sort of prognostic marker that could be used in the clinic. And we became very interested in this gene called IFI27. So this is part of the, this is an interferon stimulated gene. It's part of the antiviral response. And we became very interested in it because it looked like a prognostic marker for many different viral infections. So you can see here it's a prognostic marker for enterovirus, respiratory syncytial virus, and that it also helps discriminate influenza from bacterial infections. So I want to present to you some data that was done in collaboration and really led by Benjamin Tang at Westmead Hospital and Nepean Hospital in New South Wales. And basically what they did is they recruited patients who came in positive for SARS-CoV-2, took some blood, looked at IFI27 expression, and looked to see if it was had any sort of predictive value of disease outcome. So first of all, if you just look at IFI27 expression in COVID positive patients compared to COVID negative patients, you can see that it's much higher in COVID positive patients. If you then look at the outcomes of these patients, and you can broadly classify the outcome of these patients as either poor or good, depending on international criteria, what you can see is that COVID patients with a good outcome had significantly lower levels of IFI27 compared to COVID patients with a poor outcome. Similarly, if you look at where these patients were treated, either they ended up being treated at home, in the hospital, or in the ICU, you can see that those with higher IFI27 expression were more likely to end up in the ICU compared to those who were treated at home. And in fact, when you then go and look at the predictive value of IFI27, what you can see is that it has a really, really high sensitivity and specificity value. And this is higher than many other clinical markers that are typically used as prognostics for severe COVID-19. So lymphopenia, C-reactive protein, age, comorbidities, symptom scores, heart rate, respiratory rate, oxygen. You can see that IFI27 expression actually outperforms these other measures. All right, but I'm talking to you about a pan-viral prognostic marker. So IFI27 looks really promising in COVID-19, but what about for other viral infections? So we looked at the expression of IFI27 in the blood of patients with various different conditions. So patients with bacterial disease, patients with rhinovirus, human metapneumovirus, parainfluenza, RSV, influenza virus, and SARS-CoV-2. And what you can see is essentially IFI is increased in all these viral infections, but it's not increased in bacterial infections relative to the control. So this is sort of a promising first step that it may be a pan-viral prognostic marker. To then explore this a bit further in the context of another disease, we looked at gene expression in a cohort of patients that were either uninfected or had moderate or severe influenza. And what you can see is when you look at IFI27 expression, actually, whilst it's much higher in the influenza-infected patients, it's not significantly different between those with moderate and severe influenza. But what's really interesting is if you look at IFI27-like protein, so this is a gene in the same family as IFI27, all of a sudden you see increased expression in the moderate group compared to the control group, and then further increased expression in the severe group compared to the moderate group. So what these data is suggesting is that probably IFI27 family, that family of genes, could play an important role as a pan-viral prognostic marker that we could potentially test now and have ready on hand for the next viral pandemic. So the final thing I want to talk to you about is a pan-viral diagnostic. So obviously diagnostics are very, very important sort of to the efficacy of controlling an outbreak. And the current gold standard for diagnostics is real-time RT-PCR for viral RNA. And this is a really, really good approach because it's highly sensitive and highly specific. But it does have some limitations. So one limitation is that it's highly time dependent. So there's a period early in infection that you will test negative to the pathogen even if you were infected. Now, this can be problematic because it can delay treatment, and it can also affect how long we have quarantine and isolation procedures. It's why in COVID-19, when we had hotel quarantine, people had to quarantine for 14 days and they had to be regularly tested throughout that 14 days. And the other sort of downside, and it may not sound like a downside to current diagnostics, is that it's specific to the viral pathogen in question. So this does make it harder to stockpile for pandemic purposes, and it does mean that should a new virus emerge, the current diagnostics that we have would not be appropriate. So much like our pan-viral approach to therapeutics, we wanted to see if we could have a pan-viral approach to diagnostics. That is, could we find something in the host transcriptome that was upregulated, that could be detected before we could detect viral RNA, that would indicate that this person was infected with a virus? We couldn't probably say what virus it was from these host gene expression, but just to indicate the presence of something abnormal going on. And actually people started to look at this specifically in the blood. And what they found is that for COVID-19 patients, there's actually a suite of genes that can actually predict with very high sensitivity and specificity the risk of that individual going on to test positive for COVID. So these are markers in the host transcriptome that can predate the detection of viral RNA and predict that positive qPCR test. So there's a whole list of genes here. Of interest, the top one is our favorite gene, IFI27, but there's of course other genes in this list. Now these data are derived from blood samples. And whilst blood samples are relatively easy to obtain from patients, it's not something that you can do at home, and it's much more invasive than, say, nasopharyngeal swab. So what we wanted to do is basically look at the host transcriptome and see if we could find a marker of viral disease in these pre-positive COVID-19 patients. So we collected nasal swabs from sort of 40 samples, either negative samples or pre-positive samples, extracted viral RNA, did nanostring analysis for gene expression, and then did both supervised and unsupervised learning. Now, what I had hoped to do in this talk is to present you some of our data from this project, but unfortunately the person leading this project has actually been out sick with COVID. We're all aware of the irony here. So this will be a little bit of a watch this space, but I think the concept of a panviral diagnostic is something that we can explore. So I'm just going to finish up there, and I want to finish this talk by leaving you with 3 key questions that I want you to really reflect upon. Because I think we really need to ask ourselves, when will be the next pandemic? What will it be? And will we have learned our lesson from COVID-19 in terms of pandemic preparedness? Thank you very much.
So thank you, everyone. Ben, Vanessa, Kirsty, terrific presentations. So there's been lots of questions and you've already answered some of them in the Q&A. But Ben, starting with you, there are questions about aged care facilities in Hong Kong, and I think people in Australia might be reflecting that things could be different in Australia, where older people have adopted the vaccine, but we have had difficulties in aged care facilities. Are aged care facilities in Hong Kong at risk? Are there lots of them, or do elderly people tend to stay at home and are cared for by their families?
Yeah, no, it's a major risk in Hong Kong. We've had outbreaks in aged care facilities in previous waves. We haven't yet had them in this wave, but I think it's only a matter of time. And the low vaccine coverage is a major, major concern. Only 20%, 25% maybe now of people over the age of 80 have been vaccinated. And it's really a big problem that we're aware of. But the government is, at the minute, in my opinion, putting more effort in vaccinating 5 to 11-year-olds than vaccinating aged care facilities, which seems to me to be the wrong priority at a time when case numbers are increasing. And today, again, we have a very large number of infections, and it's definitely going up in Hong Kong right now.
Is there a question to Ben as well, Luke?
Yes, please.
Sorry, I don't want to hijack, but I'm just curious.
Yes,
has there been discussions in Hong Kong about vaccine mandates, and is there the appetite for that?
Well, we have almost a mandate now for the general community with vaccine passes as a system. But for older people, it's actually difficult. So there's a new rule just coming in that if you want to be admitted to an aged care facility, you need to be vaccinated. But obviously, most residents are already there and they don't necessarily leave. And so there's actually no easy way to mandate them to get vaccinated. And one of my general maybe feelings about vaccine mandates is that it's relatively easy to mandate for younger people. It's relatively more difficult to mandate for the eldest because they don't necessarily have any reason to need to comply with whatever the mandate results in. And that's almost a misdirection, because if we want to mandate for anyone, it's really the oldest people, not at the minute in Hong Kong. So in Hong Kong, we have a rule where 70% of children in a school need to be vaccinated if the school's going to go back to full day schooling. And to me, that's effectively a mandate on children, not quite, but getting there. And we don't have it for elderly. We don't have really any way to insist that elderly get vaccinated.
Ben, in mainland China, it sounds as though it's a very highly regulated response at the moment, and that there might be a lot of mandating going on. Is that in stark contrast to Hong Kong?
Well, I think so. I think it's not called mandates in mainland China, but obviously they have everybody's name in the list. So if it's in a city, in a town, in a village, everybody's name is on a list somewhere, and including their vaccination status. And I've heard about effectively public health officials going door to door, finding people who haven't been vaccinated and then trying to persuade them to get vaccinated, which obviously is a very resource intensive approach, but it really works. And in mainland China, the vaccine coverage is now very high, very high. And I think partly is because of a result. It's not exactly mandates, but it's making it very difficult for people to stay unvaccinated.
Ben, just while you're speaking, but there was a question about the 2080 effect and whether it develops within a variant or whether it's across variants.
Yeah, so we're trying to look at this for Omicron now. And one of our early impressions is that with Omicron, there's still super spreading, but there's a general shift upwards in contagiousness. So whereas in earlier waves, we saw most people were not contagious, with Omicron, actually, it seems that a lot of people are contagious. And then on top of that, there's still the super spreaders as well. And so we're still working out, what exactly is going on with 2080 with Omicron. But it does seem like there's this kind of shift with Omicron that the transmission dynamics are quite different in some ways.
Thank you. Vanessa, there are several questions about the autoantibodies against interferon, and are they pre-existing or are they activated by COVID, and do they correlate with clinical comorbidities such as diabetes, obesity, even pregnancy, for example?
Yeah, so we think they're pre-existing, and the reason for that is that all of the patients that we had access to pre-screened blood samples, because a lot of them were in research studies previously, did have detectable levels of the auto interferon alpha antibody. So for that reason, we think they're pre-existing. Of course, that's a fairly small subset of a large group, so it is possible that for some it's not. It does also seem that there is a boost in the levels from the SARS-CoV-2 infection as well. So there's something about being infection that sort of amplifies the autoantibody responses. It's generally linked to otherwise healthy individuals. There's no clear evidence that it's linked to any people with severe disease with those sort of known comorbidity groups, like you suggested before, obesity and diabetes and the like, other than older individuals. It does seem to be skewed towards older males. So it's interesting to understand at what point do these sort of pre-existing antibodies start to emerge and develop in how many people. And I think we really need to do more work to understand that. There is a group of patients with primary immunodeficiencies, such as patients with air mutations who have many autoantibodies that are exquisitely susceptible to COVID. And even in our cohorts, we found other primary immunodeficient people with other inborn areas of immunity are producing these autoantibodies. So there's some evidence that there are other individuals that are also affected. And the last question was pre-existing comorbidity. And what was the third part of the question, Lou?
I'm going to add to it. Has it been described for influenza?
No, it has not been described
or any
for
other
influenza.
respiratory viruses?
No, it hasn't been described for any other respiratory viruses, and there doesn't seem to be a link so far. Too soon to tell, but no indication that there's a link there.
Vanessa, can I cut in?
Of course.
I'm presuming you're talking about homozygous and not heterozygous. And secondly, you mentioned 5 genetic mutations. Do any of them hunt together? Do you find 2 of them strangely coming together on a polymorphism or something?
Yeah, it's a great question. It's a bit of a mix of homozygous and heterozygous. A bunch of them are actually autosomal dominant, and some of them, the interferon IFR7 and the interferon alpha receptor 1 are autosomal recessive, and the TLR7 is X-linked. So some of them are heterozygous, some of them are homozygous. The heterozygous ones, as with many primary immunodeficiencies, they've got incomplete penetrance. We've got to do some more work to understand that. But just to make the point that these rare genetic defects that are associated with critical COVID, they're rare, but they're not polymorphisms. They're not present in the general population above 0.1%. Like they're exceptionally rare in public databases, and they're really accounting for about 3% up to 5% of those individuals that had severe disease. And we don't see double mutations yet. No indications of double mutations.
Vanessa, thank you. Kirsty, your presentation was fantastically holistic and pan-viral. Should we be screening the whole community for susceptibility genes?
Look, I'm a virologist, not and more of an immunologist than a geneticist. So I would say you should be screening about the functional immune response rather than just based on the genetics, because it's just such a complex array of factors. I guess what I would say, and this is in response to one of the questions that it's in the Q&A, is that we can do a lot to prepare to improve our pandemic preparedness. So, there's really fundamental things that we can do in healthcare. So, for example, as Ben mentioned, improving aged care facilities. I mean, that's got to be a priority as part of pandemic preparedness, and not just improving healthcare for a subset of the community. But then on top of that, we're really excited about this idea of panviral diagnostics, and we'll have the final data tomorrow, but we're already seeing some really exciting results in terms of gene signatures that we can use for early diagnostics. And again, coming back to aged care, I think that would be a fantastic tool, because then you could screen somebody who was going into aged care, say as a worker, and know that, okay, well, they're COVID negative, but they also don't have any host signature that they're going to go on and be positive and infect somebody. So there's lots we can do on a fundamental level to improve our pandemic preparedness.
Thank you. There's a question about the timing of fourth doses of vaccine and subsequent ones, and whether it might blunt the response. I think all panelists are probably in a position to give a view about that. Kirsty, you first.
Yeah, so I guess what we know from all the various clinical studies is that the timing does matter. And certainly I think that was a big feature in the benefits, I guess, of Australia's somewhat delayed rollout of the vaccine, because we could actually time the booster for AstraZeneca and give it the appropriate time to get a better response, because we didn't have pressing COVID cases at the time. Whether or not that's going to be the case for the fourth dose, I don't know. And Ben can correct me on this, but to the best of my knowledge, I don't think we have great data out there on what the timing is for if there's a fourth dose. The timing of the third dose, I would say, is probably important. But again, how much of that is influenced by the fact that now so many people are getting COVID exposed? So you're getting the immune boost from the exposure rather than the vaccine. So it's a complex answer, I guess. But it's something that we just have to keep looking at.
Ben, you mentioned the Israelis might have some experience of fourth dose.
Yeah, I don't really have anything to add beyond what Kirsty said. I think that the Israelis found that the fourth dose didn't make that much. There was a blunted response to the fourth dose, maybe at the interval they were giving it. I imagine it would be better to wait a little bit. And then there's also a question if vaccines start having updated strains. I think just recently Pfizer said the Pfizer Omicron vaccine doesn't necessarily work that well compared to the regular, the original strain vaccine. But still a lot of questions and maybe not a lot of data.
There's a question from Wendy Pollock about structural standards related to ventilation. Given that this virus appears to be certainly spread by aerosols, possibly as well as fomites. Would any of the panelists like to talk about structural measures?
Ben, do you want to do that one?
Yeah, well, I was just thinking I don't have a lot to say. I think it's important. And in Hong Kong, we've had a number of outbreaks where ventilation's been proposed as a major shortcoming. For example, in restaurants, and there's been rules discussed for restaurants, so they have to have a certain number of air changes per hour. But within a short space of time, I'm not sure how in Hong Kong, particularly in restaurants that are typically in bigger buildings, in shopping malls or residential complexes, how they can improve their ventilation in a short space of time. It seems like maybe a longer term project to try and improve ventilation of all kinds of buildings, not only restaurants, but all kinds of businesses and residences and everything. But I'm not sure what can be done in the very short term, although we recognize that it's a big issue.
And a quick comment about protein-based vaccines. Do they have advantages?
For me, I would have thought they do. As far as I can tell, the reactogenicity is preferable to maybe mRNA vaccines. And as with the mRNA vaccines, they can be very, very precisely designed. So there's a lot of potential advantages, but they've taken a long time to get into the market. I think Novavax is just very recently approved in the UK. And so, I wish we'd had it earlier. I wish we'd had it earlier, but looking forwards, I think that a lot of countries will be looking at that technology as something on the level of mRNA vaccines.
Yeah, well, I think the protein vaccines are just inherently more affordable to produce. So, of course, that's a massive benefit because then you have widespread access. I've seen the same data saying that the reactogenicity is less, but I'm always very hesitant about that because we do have a subset of the population who are saying, oh well, I'll wait for Novavax, and that's a very, very risky game if you've got COVID in the community. So yes, I think protein vaccines have a great role to play in this pandemic, but it doesn't mean that you should be holding out for them.
Yes, I'll just make one point in addition to the great points just made is in terms of vaccine equity, there's certainly advantage of the protein-based vaccines. They've got longer shelf lives, lesser restrictions around what temperatures they need to be kept at. So obviously that's also a consideration if we want to vaccinate the world quickly as well.
We've just got a couple of minutes to go. I'm conscious of the human effect on scientists. You've been in the thick of it for 2 years, and it's not just sort of dealing with a deadly condition, but someone mentioned the word politics. Kirsty, you did. Briefly, are the three of you travelling okay? And do you think there's a specific burden for scientists in this time?
It's a really good question. The last 2 years has been insane. I think all up maybe 4 days off over the last 2 years. It's just been nuts. It's been scientifically very exciting, sometimes very frustrating because you just finish a piece of work and a new variant comes along, so you've got to do it all with the new variant again. But I think probably the biggest thing that I noted was the enhanced sense of responsibility and the fact that people were really depending on the results and especially doing things with vaccine efficacy. People are waiting for the results to actually make direct public policy. So I think the translation of the fundamental science to policy and improved healthcare has just been an experience, let's say an experience.
Thank you. Ben, you've been in the thick of it and at the top of the tree, leading a team.
Yeah, so my team have been working non-stop as well for 2 years, and we're all pretty tired now. But it's going to get busy again in Hong Kong because of Omicron. And one of the things that we've had to spend a lot of time doing is kind of trying to help communicate what we think is the situation at the same time as a lot of other new experts. There's a lot of people who've suddenly become experts in my case, in epidemiology. In Hong Kong, we have an awful lot of infectious disease epidemiologists now who've come out of the woodwork, who didn't used to be until quite recently infectious disease epidemiologists, and trying to give our opinions at the same time as other people are giving their opinions, and then trying not to have public fights, but at the same time trying to correct what's almost, it's not official misinformation, but it's misinformation from very respected people. For example, just a week ago, one of my esteemed colleagues said that the current Omicron wave will be over in a few weeks. And I'm looking at the numbers going vertical and thinking, how is this over in a few weeks, unless it's over the other side of the mountain in a few weeks? because it, but I'm not going to go publicly and talk about that. So that's one of the current difficulties, that there's a lot of official related sources that we have to try and communicate and deal with.
Ben, thank you. Vanessa, a yes or no, is research money easier to get in times of COVID?
Absolutely not. Absolutely not. There's there are targeted opportunities. There, as always, quick turnaround time. Bung it out, do it as you're doing the research. The success rate is as poor as ever. We've had some good funding, but it's as tough as ever. As always, we need more funding in translational research as well as basic research. That's our mantra. The reason we had so many vaccines, 18 across the world so quickly, is really the last 20 years of research on these diseases. It didn't start from scratch. It was a large body of work that it was built off, and it just shows we need to continue that funding, and that's one of the many ways we can be pandemic ready for whatever comes our way next.
Fabulous last words, Vanessa. Thank you. I'd really like to thank the three of you, Ben, Vanessa, and Kirsty. Wonderful opening session. Take care, all of you. Thanks very much.